some kind of, we have a whole outreach arm within Kaiser of, you know, mailing and calling and asking these people to come in and try to reduce co-payment barriers for them. You know, come in for a free nurse blood pressure check. You know, so you don't have to necessarily schedule and have a co-payment with your doctor if the cost is a barrier. The doctor can just titrate you by phone if you come in and get the nurse to check your blood pressure. So trying to reduce barriers and do in-reach and outreach, kind of a combination of things, and then having the electronic health record programmed with whatever guidelines your system is using and the protocol that we chose. Somebody mentioned Crinzide as our first choice for blood pressure, and we also use the ACCHA blood pressure, cholesterol guidelines. And I'm working with AHRQ group there's a repository they're building for electronic decision support. So any federally qualified health clinic, for example, in LA, can go to this repository and grab this computer code that has the ACCHA cholesterol guidelines all ready to run on individual patients and say, oh, this person's ASCVD risk is 16%. Start statin, start aspirin. You know, real simple messages like that. And you can even tee up the orders so the doctor just has to sign it. That's how we try to tee it up for doctors, that it's easier for them to just sign it and send the patients on the meds than to just treat the back pain and to undo all that, because we tee it all up in the health system. That it's almost the path of least resistance is treating patients the right way.
I think that's key.
Yeah.
We figured out with our CHIMP protocol a long time ago. Everybody wants to do the right thing, and if you make it the easy and the default thing, they'll do it.
Yeah.
How about Kelly Green and then Carol Zaher?
I'll just add a couple more things onto what Ron said. Kelly Green, also from Kaiser. We champions are huge advocates, physician champions, pharmacy champions, and a lot of our infrastructure is built on these, powerful, enthusiastic champions that push our leadership to do the right thing and push their peers to do the right thing. Unblinded performance measures are huge in Kaiser. When I came here 15 years ago, a few of our medical center areas, I think Orange County was one of the first to start doing unblinded share. They send it out in an email, the charts right there, pasted in with their performance for blood pressure control. We've been doing more and more telephone visits. It's mushrooming because it's so convenient for patients. And academic detailing, and that's not high tech. If you have systems that have experts that can go around, when you identify your providers who are not good performers and somebody stops by, our pharmacists do a great job on academic detailing. And really, when it comes right down to it, when you look at your really good performers for blood pressure control, their patients love them, they don't have a high no-show rates. So often it comes down to how you do it. And when Mike Cantor says to me, our head of quality for all of Kaiser, well, why does this provider do so well and that provider doesn't? I say, you can't change the way this provider talks. You can do a lot of coaching, but even care managers on the phone, you've got some that are really good, and those patients just want to do and they're very good. And you've got some other care managers, it's so much of it, when it comes down to that 2% difference, 3%, 4%, it's how you do it. That's one you kind of can't train. Train it a little bit, but not really.
Yeah, sharing the best practices, though, with the unblinded data, you can bring a lot of the lower performers up. And so over time, some of the low performers sometimes become high performers. They put a lot of energy into it.
So we had a question from Carol Zaher from HealthNet.
Yeah, let me just comment. In a former life, I was at Kaiser, and the things you mentioned are absolutely, well visited there. And I was part of the initial process many years ago when the unblinded data started coming out, and that was quite dramatic for those of us who practice, because doctors tend to think we're all doing 95%, and when you get the statistics, sometimes it doesn't reveal that. So that, I agree, somehow bringing the data out and showing where you stand amongst your peers is nice. And also what you said about 80% the in-reach, which we're calling that, I think that's where a lot of the rubber meets the road in getting practice changed. And as you said, making it simple. You can make the simpler you can make it for the doctor who has obviously a lot of things to do, and, you know, a lot of being pulled in many different directions. But if you can make it really simple, to do some simple things, I think that's the great first start. With respect to the outreach and the patient, I'm just, you know, talking about billboards and whatnot. I just, and Dr. Watson, you sort of mentioned this, how can we get with the dermatologist for melanoma and skin cancer? I, just yesterday, I think I was watching television, which I don't do too often, but I was sort of mindless. And it struck me that there was a commercial for 1-800-QUIT for smoking. And it was a woman who, you know, had a trach and sounded awful and looked bad. And, you know, that's very dramatic. Now, it still doesn't get everybody to stop smoking, but it does get some attention. About an hour later, I was watching some other show that talked about a family member who had died of a heart attack, and the son hadn't gotten there in time. The father passed. And the son's comment, which I thought was interesting, was, you know, he felt guilty about not getting there in time. And he said, well, you know, everybody has a heart attack, and, you know, most people survive. I thought, you know, we had time to get there, that this isn't, you know, as big a deal as maybe in the old days. And when I heard that, I thought, oh, yeah.
You're exactly right. We are a victim of our success. No one's afraid of it anymore because we all do such a great job of keeping patients alive. We're still really afraid of stroke.
Yeah, that's right.
We're really afraid of cancer.
Right.
They're not doing as good a job as us.
I was just going to, because my clinical background is as an intensive care physician, and I'm somehow thinking about those discussions you have with families, you know, those last days when everybody knows the patient's dying on the ventilator and everybody's just hanging out for that miracle that might happen, and thinking about, to your point, how do you rewind that realization of really time's up here to, oh, if only, you know, he'd lost weight and we've done all those things, because somehow in cancer there's that connection. But for heart disease, and we seem to somehow, I think, have lost a little bit of that connection about where we could end up. So I think it's, going to your thing about the adverts, I'm struck here that maybe I don't watch enough TV here in the US, but I'm struck by the UK will do brutal public health television advertising, like really brutal. I don't know if has anybody seen the one, if you've ever been in the UK, there's one about putting a seatbelt on in the back seat, and the mother is taking the child to school. She jams on the brakes, and the child shoots forward and decapitates the mother on the school run. Now, that didn't take long to get everybody putting their seatbelts on. So